Yeah. So to begin with, I think whenever we are discussing a lump in abdomen case, uh, there are a few points which we need to consider whenever we are suspecting any lump in abdomen. So the basic thing that you are expected in any lump in abdomen case is what the lump would be, and based on a quadrant and based on history findings, and then coming to a diagnosis. So in every case that you get, there's some expectation from you based either be the treatment part or the diagnosis part. So in any abdominal lump, the most basic thing that you should know, be able to at least rule out at least two differential diagnoses for the lump. So the most important thing that comes in this part is seeing where the lump is, and then having a diagnosis in your mind, or at least two diagnoses or two DDs in your mind whenever you know the history and the lump. Okay. So to understand it, I think the most important thing is you should know all these nine quadrants. If I hope you can see the screen. Yeah. So right now today we'll be discussing just the epigastric region. Starting with this. Yeah, another thing. There's an issue with my this thing, the marker. Oh, the email is gone. Yeah, there's an issue with the pencil. It's not working properly. I hope you can manage. Yeah. So coming to the epigastric lump, the first most important thing what we discuss with in an epigastric lump is what are the organs or what are parts of the organs that you get in that region. So the most important thing, the first thing that we all know is the stomach. Okay. More likely the stomach, the antral region and the pyloric region, followed by the pancreas. Okay. And then comes the esophageal region, which is less likely. And so anytime you get a lump, the two most likely disease that I will think of in an epigastric lump will be the first thing will be whether it is benign or whether it is malignant. Okay. Sorry for the pencil thing. Yeah. So if it's benign, most likely benign cause will be first we'll look at a gastric cause. Okay. A gastric cause will be something that is the most common a diagnosis that you get in stomach is a gastric ulcer. Okay. Gastric ulcer and followed by a duodenal ulcer. Okay. Now, whenever there's gastric ulcer, duodenal ulcer, there's some fibrosis at the region of the outlet of stomach in this part. Okay, and later on it leads to distension of the stomach. Okay, so this condition is known as your gastric outlet obstruction, which is the most common lump or usually quite commonly seen in this region. Apart from that, it can either be a malignant lump, CA stomach. Okay, or secondly, it could even be a pancreatic lump because pancreas are located just behind the stomach in this region, exactly in this region. As soon as you lift the stomach up, the first thing, and you go in the lesser sac. So what is lesser sac basically? If this is the stomach, okay. So if this is the region of the stomach, and there is the omentum attached to it, okay. As soon as you lift the omentum up, okay, and you go in between the stomach and the colon, you enter the area known as lesser sac. I hope you have learned all of this in your anatomy, okay. So as soon as you go in the lesser sac, uh, the first thing that you get just behind the stomach is your pancreatic region. Pancreas are located somewhere over this region, exactly at this region, just behind the just behind the stomach, and below this continues your duodenum, somewhere like this. Okay, so a gastric either a benign etiology or a malignant etiology, or at the same time a benign or a malignant pancreatic etiology. All these four possibilities are the most common possibilities I'll consider in a epigastric lump. Okay. Rest of the areas I think we'll consider whenever we discuss those lumps, and maybe we can just move on right now with epigastric lump, focusing on epigastric lump. And just yeah. So coming to any epigastric lump, whenever we discuss an epigastric lump, there are few classical symptoms that a patient comes with. The most classical symptom, most of times in early cases, if it's a malignant lump, the patient can be asymptomatic. But to start with, the symptoms are very mild. Okay, they start with dyspepsia. I think I've not written it over here. Okay, and there's something known as distension. Now, distension, you have to be very specific when the patient describes distension, because distension can either be localized to the epigastric region or any specific region of the abdomen, or it can be generalized. Now, you know very well the most common cause of generalized distension is your ascites. Okay, so ascites is one of the most common cause of generalized distension. There are other causes. There can be huge lumps that can occupy the entire abdominal cavity, but ascites is the first most common cause. Distension in these cases in an epigastric lump obviously will be in the epigastric region. Uh, Something like gastric outlet obstruction can lead to your distension in the epigastric region. Second thing that you can, so that is important. Whenever you describe the history or the HOPI, you have to describe where exactly the patient is describing his distension, और patient कहाँ पे बोल रहा है कि डॉक्टर साहब पेट फूला फूला लग रहा है. So that is what the most common complaint the patient says. Okay. Second thing is your pain. Now, pain is a broad thing which includes many points. Okay, so I think we'll discuss it later. We'll just see the symptoms, all the chief complaints over here, and then we'll move on to each and every one separately. Okay, so pain, we'll discuss this separately. Vomiting. So vomiting, in this case, usually whenever there's obstruction, because in the either in the pyloric region or in the antral region, whatever the contents are taken in the stomach, they don't move ahead. Okay. So what happens is whatever food particles are there, they eventually end up getting vomited. Okay. So the most classical history that you get in a patient of gastric outlet obstruction is vomiting associated with undigested food particles. Okay. And many a times patient can even say that food that he has eaten at the 1 or 2 days before is even vomited, because there's traces of the food and the stomach is grossly distended. So there's bouts of vomiting usually 1 to 2 hours after every meal. Sometimes if it's severe, it's even immediately after meal. But this is the most common history or most significant history that you get in a patient of gastric outlet obstruction. Another patient where you can get a similar history is, suppose there's okay, I think you know what. So as I've described this before, this is the pancreas. Okay. So what happens is, if you know something, you know a condition, a benign condition related to pancreas, that is your pseudocyst. Okay. So pseudocyst, usually what happens is the main pancreatic duct comes in communication or gets acted upon by the enzymes, and then the secretions are released over time, leading to formation of a cyst or a pseudocyst. It's not lined by epithelium, so it's a pseudocyst. Okay, and this pseudocyst, as it gradually grows, it causes compression on the stomach wall. Okay, and if you see on a CT scan, many a times you'll see that the stomach is completely compressed. Okay, it's anterior posteriorly flattened, and the entire gastric space is occupied by the pseudocyst. So this is another condition where the patient will complain of vomiting immediately after consuming food. So pseudocyst, along with pain, the pain that you get classically in any case of pancreatitis, patient will also complain of vomiting. Okay, vomiting that is usually seen immediately after consuming food. The next thing that you see is dysphagia. Now, dysphagia is something that is more common with lesions that are high in the stomach. Okay, so any lesion that is somewhere over here. Okay, so this lesion usually is where the patient will complain of dysphagia or something higher, maybe in the esophagus or the lower end of esophagus. Okay, so dysphagia, again, it's less specific for epigastric lung, but more of a higher lung. Then this is another important history that patient complains. Either the patient can have hematemesis, or he can have melena, or he can anemia or melena. So what happens is any malignant growth in the stomach, because it's a fresh lesion or freshly granulating tissue, and there's active ulcer. If the ulcer is based on a vessel, patient will have chronic bleed. Smaller vessel, patient has chronic bleed, or if it's a bigger vessel, patient will cough up the thing, vomit the blood, and patient will present with hematopoiesis. Many a times patients of CA stomach, this is very important. Many a times patients of CA stomach, the only presenting feature is anemia. So any patient who comes, old age patient, usually 60 plus years, who comes with anemia, after ruling out all the hematological causes, you have to do an endoscopy and a colonoscopy to see whether, or before that, we even do a stool occult blood. Now, what is stool occult blood? Whenever there's any form of blood, either dice or undigested, it's picked up by your stool examination. Okay, that is known as stool local blood, which is tested, which detects even minimal amounts of blood that is present in the stools. So if that test is positive, you go ahead with an upper GI scopy or a colonoscopy. So, because CS stomach, many a times the only presenting feature is anemia. Okay, so this is very important that you all should know that anemia is very important as far as an old age patient is concerned. Okay, and CS stomach patients till even till late stage, the only presenting feature can be anemia, and over a period of time they can complain of weight loss, loss of appetite. Okay, similarly, because of blood loss, the patient will have hematopoiesis and the patient will have melena. Okay. Uh, Melena, there's another important thing that I need to tell you with melena. Uh, Many a times patient complains of black colored stools. Now, not all the black colored stools that you get are is melena specifically. So, melena is when the patient has dark colored hair colored, or patient literally says this कि बाल जितना काला stools है. And the second most important thing is it's hard to flush. Okay, so these two things are very important when melena is concerned, because there's another reason for black colored stools or black pigmented stools, that is your iron sulfate, ferrous sulfate, sorry. Okay, so patients who are on oral iron supplements, they can have black stools, or they usually have black stools. So not all patients who have black colored stools necessarily have upper GI bleed. Okay, so that is important. You even need to ask a history if the patient is on any type of supplements for the anemia that has been given before. Okay, coming to next complaint, that is your anorexia and weight loss. Now, I've always been stressing on this important point that there's a significant difference between anorexia, early satiety. Whenever a patient comes to you and he says that भूख कम लगती है, that is what typically anorexia is. Okay, but at the same time, if the patient complains of early satiety, या फिर डॉक्टर साहब भूख तो लगती है लेकिन खाना कम जाता है. Okay, so this is your classical early satiety. And both these symptoms are very important when you're seeing an epigastric lump, because early satiety means that the patient is having a lump or some lesion in the stomach, and it's occupying the entire gastric space. Okay, so naturally the space for the food will be less, and the patient will have early satiety. There's a very common another common symptom that is seen, or not common, but it's seen in more advanced stages in a case of CS stomach. Okay, so you need to differentiate whether the patient actually has this thing, uh, loss of appetite, just this thing, early satiety. Okay. Along with that, weight loss. I think everyone by this time knows the definition of weight loss. Uh, when is it 5% and when is it 10%? Okay. So 5% over a period of last 3 months, or 10% over a period of last 6 months. All of this is important. Okay. So anything significant, anything more than this is your significant weight loss. Okay, these two definitions are very important, and many examiners they end up asking this definition in your history itself, the classical definition of weight loss. Okay, yeah. So coming to the most important symptom, that is your pain. whenever we're discussing pain in an epigastric lump, I think all of us know that there's a huge difference between a gastric pain associated in a peptic ulcer and a gastric ulcer. I mean, a peptic ulcer leading to. So what happens is, gastric ulcer, the ulcers, they are usually uh, they come immediately in contact with the acids and the stomach and the food. Okay, so as soon as the patient consumes food, the first pain that the patient gets, okay, that will be the pain of your gastric ulcer. Typically, the patient says that as soon as he consumes food, the patient will have pain, and that in a way leads to uh, decreased appetite of the patient. Okay, not appetite, but decrease food consuming by the patient. Now, in this case, again, the patient's appetite is good. Okay, he he'll say that उस भूख लगता है लेकिन खाने के बाद दर्द होता है इसलिए खाना कम हो गया. This is the most typical symptom that the patient will say in a case of gastric ulcer. Okay. Now, because the pain that is there is caused because of the food that has been consumed, it is usually relieved by vomiting. Okay. So this is another thing that the patient says, that as soon as he vomits, that he has to vomit food, and immediately there will be pain relief. Other things that can obviously lead to pain relief is your alkalis and your PPS and all. Okay. But this thing is more important. How the pain is. Vague, mild discomfort, whatever is written, all of this. Clock-like regularity, exactly. So because the patient consumes food in three intervals, the pain will exactly be in three intervals. Okay. Unlike a duodenal ulcer will usually have a diffuse, long-lasting type of pain. There's no specific time for when the pain will be. It can be either 2 hours after food or 4 hours after food, based on when the gastric emptying is happening in that patient. Okay. And usually, duodenal ulcers, the patients are young males. Okay. It's usually associated with high risk of smoking. Okay. And because the duodenum is slightly towards the right side, the patient usually complains of pain that is more in the RSC region, epigastric plus RSC region. Okay. Second thing that you get in this case is, as it is written here, hemorrhage and marina. Because I think you all know that exactly exactly behind the duodenum there's the vessel. Now, anyone would like to point out what this vessel exactly is? No one? Okay. So this vessel is your GDA. Okay. Now this vessel it arises from the trunk, sorry, the celiac trunk, and then it lies just behind the duodenum. So whenever there's a posterior duodenal, so that is on the posterior wall, okay, the most common complication of a posterior duodenal ulcer is bleeding. Okay. And at the same time, if the ulcer is on the anterior wall, in that case, the most common complication is your perforation. I think this thing is very important. You should never ever forget this point. Okay. The differentiation between an anterior duodenal ulcer and a posterior duodenal ulcer. At the same time, when there's ulcer present on the anterior wall plus the posterior wall, this is classically known as your kissing ulcers. Okay, so this is just a theory point, but yeah, so that is the reason why you get more amount of hematemesis, melena, anemia in a case of duodenal ulcer. Now, coming to the next point, both of these ulcers can lead to your cicatrization in whatever region they're involved, because gastric ulcers are more seen on the lesser curvature. Okay, over here, the presentation of a gastric outlet obstruction is less common in this region. Okay, if it's higher, usually GOO won't be seen. But at the same time, if the ulcer is seen somewhere near the pylorus or in the duodenum, okay, patients will typically present with GOO. GO, again, gastric outlet obstruction, okay, which again can present either because of a benign etiology or a malignant etiology. Benign etiology can be your ulcers, okay, and your malignant etiology will be classical CS stomach. Apart from this, there are few other reasons which I think need a small stress over here. You know the congenital condition that you see more commonly in children, okay? Congenital hypertrophic pyloric stenosis. Okay, this is another most common cause of gastric outlet obstruction. Okay, there's one more thing that reason for GO, that is Bourette syndrome. Okay, now right now I'm not going to say or tell you exactly what Bourette syndrome is. I want you all to go and search what exactly Bourette syndrome is, and maybe tell me later or text later, whatever is fine. But it's one of the most it's not very common, but many times you ask this question in theory that what exactly is Bourette syndrome. Okay, so the spelling is what is written exactly over here, Bourette syndrome. Yeah. So coming to gastric outlet obstruction, as we have discussed before, we have already discussed what type of vomiting you will get. Okay, in GO, all those undigested food particles. Okay. Secondly, patient will have weight loss because decreased appetite plus the vomiting. Okay, that is a very common feature. There are many examination findings that we'll again go and discuss in, but there's one specific finding that you get in a case of GO, that is your succussion splash. Okay. Now the drawback with this clinics is I won't be able to demonstrate exactly how you do a succussion splash, but I'll try to draw. Okay. So what you do is the patient lies on one side. Okay. You usually the patient. Sorry, I'm not good with drawing. But so suppose the patient is lying laterally. Okay. The most preferred position that you get that I think is a right lateral. That is, the left side is up and the right side is down. Okay. So in that position, the patient can move well. Okay. So supposing this is the right side of the patient and this is the left side of the patient, what you do is you suppose this is the epigastric lesion. Okay. What you do is with the bell of your stethoscope, you keep it exactly in the epigastric region. Okay. And because there's GO, there's so much of fluid in the stomach that when you move the patient, so you hold the patient, the left hand side of the patient, and you literally move the patient. And with your right hand, you keep the bell of the stethoscope exactly in the epigastric region. And when you move the patient, the fluid that is inside the stomach will move along with the patient. And this can be heard as a splash or splashing along the walls of the stomach on the stethoscope. So this exactly is your succussion splash, which is very classically seen in the case of gastric outlet obstruction. Okay. So many a times you're asked to demonstrate what succussion splash is. Okay. I think you all know what electrolyte abnormality you get. You have already studied, many of you must have already studied this in heat surgery or congenital hypertrophic pyloric stenosis. So you get a very classical hypochloremic, hypokalemic metabolic alkalosis. Okay, along with paradoxical aciduria. Now, I think you all know why you get all this part of the electrolyte abnormality. But I'm more interested in why do you get this part. Okay. Now, all those who have joined, I actually want someone to please tell me why do you get paradoxical aciduria, because this is a very important thing. I think it has been asked in one of the exams as well before, in one of the NEET exams. Why do you exactly get paradoxical aciduria? And in spite of the patient being in alkalosis, okay, because that is exactly why the word paradoxical is given. That if the patient is in alkalosis, why is acid being excreted? Okay, so anyone who would like to maybe come ahead and let me know, or I think maybe after some time. Yeah. Okay. I think by the end of the discussion, we'll come back again. Why do we get it? Okay. We've already discussed the causes of GO, and they're very important whenever you get a case of epigastric lump. Okay. Yeah. So till now, we have already only discussed about gastric causes of epigastric lump. Okay. So starting from peptic ulcer and then coming to all those malignant and benign causes as far as history is concerned. Okay. Now we'll come to the pancreatic region. Okay. So pancreatic origin pain, as we all know, the pain usually starts with epigastric region and then it radiates to the back. Patient classically complains of pain that he has severe intense pain in the epigastric region, and the patient's one hand is on the epigastric region and second hand is on the back. This is the most classical picture seen along with the patient lying leaning forward. Okay, because that sort of helps with relief in the epigastric pain or pain of pancreatic origin. Okay. Along with this, the patient complains of multiple episodes of vomiting, whether it is a benign cause or a malignant cause. Okay. Now, if the same patient, this please read this history: epigastric pain radiating to back with, sorry for the typing error. Epigastric pain radiating to back with history of bench alcohol intake before pain that was there 1 month back. Okay. So if a patient comes to you with a history of chronic abdominal pain that is more in the epigastric region, and he had one episode of pain that for which he had to take injectables or either get indored for a day or two, okay, and that just before the pain episode, the patient had episode of a binge alcohol intake, okay, or a episode of jaundice, okay. So this classically is a pain of your pseudocyst, okay, or pain of chronic pancreatitis. Pseudocyst is a better word. Chronic pancreatitis per se is this won't come under chronic pancreatitis. It's more of a pseudocyst. Okay. So what happens in pseudocyst is because any pancreatitis, whenever patient goes in an episode of pancreatitis, okay. So what happens is, so whenever any patient goes in an episode of pancreatitis based on the severity, okay, we usually use the CTSS score for severity. Based on the severity, there's leaking of all the contents of pancreatic contents in the peritoneal space. Okay, that eventually leads to uh, collection of the contents in the lesser sac. Okay, and all this fluid that collects in the lesser sac eventually forms a cyst-like space in the lesser sac. Now, this space or the lesser sac space does not have a proper epithelium. Okay, so this is the reason why it's called a pseudocyst. Okay, because it does not have a significant or proper lining epithelium. Okay, now this cyst, as it keeps on growing, this now there's a definition which is usually given that whenever there's collection, okay, whenever there's collection less than 4 weeks, okay, it's usually labeled as peripancreatic fluid or acute peripancreatic fluid. But whenever there's this goes beyond 4 weeks, the body tries to contain it in a space. Okay. And this contained fluid is then itself labeled as pseudocyst. Okay. At the same time, uh, whenever we, whenever a patient comes to you with pancreatitis, after a period of 72 hours, we subject the patient to a CECT, contrast enhanced CT abdomen. Okay. And in that case, we have to see if the patient is in pancreatitis, we have to see two things. Okay. One is the amount of fluid collection that is there exactly around the pancreas. This is one thing. And the second criteria that is used for CTSS scoring, CT severity index, okay, or also known as Balthazar grading system. Okay. So the second thing that is checked is your necrosis. Okay. So what or how much portion of the pancreas has undergone necrosis? Is it 30%, 50%, okay, 20%? And based on this grading, we give a scoring which is known as CTSI. Okay. Now, because we have already described fluid in a case of pancreas that either it can be peripancreatic fluid or it can be pseudocyst. In the same way, if there's necrosis of the tissue, okay, this is known as acute necrotic pancreatitis or necrotic pancreatitis. Okay. But again, if this necrosis goes beyond a period of 4 weeks, this is known as VON. VON classically stands for walled off necrosis. Okay, you'll very commonly see this word whenever you are reading theory of pancreatitis. Okay, so this word is another important word, which I think the word itself you should know. Is whenever necrosis extends for a period of more than 4 weeks, it's labeled as walled off necrosis. Okay, and for both these conditions, you have to do a drainage procedure if they are significant or causing symptoms. Okay, it can either be external drainage or maybe if not, if it does not resolve, it can be a surgical drainage. Okay, so this classically describes your history in the case of epigastric lump. Okay, again, whatever history we have seen in a gastric lump with this epigastric history of pain. The second history is early Saturday because of the compression on the stomach. That is because of the pseudocyst. Okay. Second is because there's pain. Again, the patient will have appetite, but the patients will because of the pain, the patient will have a decrease in food intake. Okay, so that is again significant, and along with weight loss. Okay, I think right now only we'll discuss what symptoms a patient has in a case of chronic pancreatitis because that is somewhat different. Okay, CP or chronic pancreatitis is usually seen when episodes there are recurrent episodes of acute pancreatitis. Okay, so constant acute episodes of recurrent episodes of acute pancreatitis leads to damage of your pancreatic tissue or chronic necrosis. Okay, because there's a sequential loss of pancreatic tissue at a point, after a point of time, the amount of pancreatic tissue that is remaining goes significantly low. Now, because of this, two functions are affected. Okay, the pancreas in your body they have two functions: endocrine and exocrine. Okay, what is the exocrine function of pancreas? Whatever functions are seen in the islet cells. Okay, what are the islet cells? Sorry. I think okay, yeah, islet cells: alpha, beta, delta. There are even other cells. Okay, but I think these three are important. Alpha, you all know glucagon, insulin, and somatostatin. Okay, so whenever there's decrease in these cells, the most common symptom that you get is diabetes mellitus. Okay, so again, if there's a lot of destruction of pancreatic tissue, we leads to something known as bronze diabetes, okay, which is classically seen in the case of your chronic pancreatitis. Now, if there's loss of islet cells, okay, there's loss of all the enzymes that are required for your digestion. Okay, mainly the amylase, lipase. Okay, so this eventually leads to loss of fat absorption, because that is the most significant thing that is seen with your pancreatic secretions. Okay, because this fat loss of fat absorption, you know that ultimately it leads to loss of fat soluble vitamins. Okay, so you'll have symptoms of deficiency of A, D, E, K. Okay, I think I won't go in details of what all they are required for. But whenever there is a patient of chronic pancreatitis, you have to focus on three things. One is the exocrine function. Second is the endocrine function. Okay, and third thing is the pain itself. Because patients of chronic pancreatitis, the most common symptom is pain. Okay. Another thing that is there seen in this case of chronic pancreatitis is because there's loss of fat absorption. The patient classically complains of stools plus lipids. I think you all know what that is, steatorrhea. Okay. So patient complains of sticky stools that are hard to flush. Okay. Sticky oily stools sticking to the pan. This is the most common history or most significant history that is seen. And whenever you send the sample for stool RM, okay, there's high lipid content in the stools. This is again, there are many tests, many direct and indirect tests. I think when you read the theory, you will know better. Okay, so based on fat estimation and the enzyme estimation, there are either direct tests or they are indirect tests. Okay, coming to examination, I think we have discussed most of the points of history. Many times the examiner asks you in the exam what diagnosis you have come to with after discussing all the history. So with this much of history, I think you can come down to a diagnosis. Either it's a pancreatic lump or a gastric lump. Okay, benign or malignant, whatever the etiology is. Okay, pancreatic lump again. Patients can sometimes present with features of periampulate CA, but then periampulate CA, the lump won't really be palpable. Instead, the patient will have something known as a palpable GB. I think most of you who have finished your surgery postings know what Corvazzo's law is by this point of time. Okay, but then pseudocyst and your malignancy, along with CA stomach and other causes of CA stomach, this thing, gastric lump. I think these four are the most important thing that you should know as far as your epigastric lump is concerned. Okay, basic things, other basic things like your general past history, medical history, gynecology history. I think I don't need to discuss. You already know what all is asked, and better not go over there. Okay, whatever is significant in this case is you'll have to see. There's or maybe I think I'll discuss it as a question later, because that's a very interesting question. Okay, which is somewhat related to your history point of view. Okay, so we'll now come to examination part. There are a few general points which I want to discuss before uh, discussing core examination part, because these points, many a times you fumble on these points at the time of exam, and then the examiners don't let you go to the proper examination part. Okay, so the first most important thing before starting any examination for any patient is consent. You have to explain the consent in whatever language the patient is comfortable. Okay, so you have to start with आपको कौन सा भाषा आता है. Okay, whatever language he is comfortable with, mostly it's Hindi, and then you have to start with that you want to examine him, and then is he comfortable with the examination. Okay, so this is a simple question you can ask in front of the examiner. Apart from that, elimination, you have to describe that it's a well illuminated room. Okay, position, you have to describe what all positions you have examined the patient. Okay, sitting position, supine position, lateral position. Okay, all of this is important. Okay, if I've done a PR examination, sixth position also you have to describe. Okay, next thing that comes is exposure. If it's abdomen, nipple to knee exposure is very important. Okay, if it's neck, your entire exposure should be till the nipple, starting from the entire face. Okay, so all of these points you should know, like well exposed and well illuminated room. All of this you should know. Second thing is warm hands. Always, this is a good practice to, before palpating the patient, you should always make your hands warm and then palpate the patient. Okay. So these points I don't need to tell you in detail, but all of this is very important. Secondly, the consent part, I think we have to discuss many consents about for the OSCE part. I hope I'm able to take a session for you because that is a significant um, drawback which you all have because you don't have really have patient exposure, so you don't know how you explain consent for many of the things in surgery, either stoma consent or a malignancy, this thing to a patient. That is one point I would like to discuss with you later on when we discuss OSCE or when we discuss instruments and OSCE separately. Okay. Yeah. Uh, Coming to examination, am I going too fast? I think I will just take a check over here. Anyone wants to give a review about whatever we have discussed as of now? You can text or maybe you can just unmute yourself and give a review. If everything is okay, we'll just move ahead. Or if I'm going too fast, please let me know. Okay, we'll continue. Thank you. Yeah. Huh. So, coming to examination, in an epigastric lump, we'll discuss the points that are specific to an epigastric lump. Okay. As we have all discussed, pallor, as I've said, that anemia is quite common in a case of epigastric lump and gastric malignancies. Okay. So pallor is very important. You have to see if the patient has pallor, and that goes again in favor of a malignancy most commonly. Okay. Second thing is icterus. Now, icterus is less likely in an epigastric lump or a gastric lump, but when we discuss OJ, one of the DDs that we or a differential we will discuss is a lymph node. So, uh, your stomach has multiple lymph nodes which go towards the greater curvature and your lesser curvature. Okay, your greater curvature, your lesser curvature. Okay, so there are lymph nodes which you'll find in the along the entire greater curvature, lesser curvature. Okay, this is your duodenum. Okay, this is your CBD. Okay, so the stomach, along with these lymph nodal basins, that is just exactly adjacent to the stomach. The stomach also drains in lymph nodes that is along the CBD, along the hilum, okay, along the vessels, your left gastric, right gastric, okay, your right epiploic, gastroepiploic, left gastroepiploic, okay. So all these lymph nodes, all of these lymph nodes they drain the stomach, okay. So whenever malignancy goes from this part to a lymph node that is exactly near the CBD or the bile duct, okay, it causes compression on the bile duct, okay. So this is a one of the important DVs that is seen in malignant CA stomach, OJ with an epigastric lump, okay. So that is a that is actually seen quite commonly because most of the CA stomach that we get are usually in advanced stages, okay. So many a times there's obstructive jaundice, which is mainly because of either because of the pylorus. If there's a growth in pylorus, even that can go and obstruct the CBD at this part, okay. Or if there's a lymph node, it can go and obstruct the CBD, okay, higher up. So this is one DD you should remember, or one differential you should remember for obstructive jaundice with your epigastric lump, okay. Lymphadenopathy. Now, lymphadenopathy, as I've discussed just now, you can get lymph nodes in along all the areas as I've described before, because all these lymph nodes they come under D2 stations. Okay, so stomach lymph nodes the Japanese have divided the lymph nodes around the stomach, around the entire stomach, into three parts. Okay, D1, D2, and the D3. Now, this is not really important for you, okay, because these are the level of lymph nodes along the vessels. Whatever lymph nodes are close exactly to the stomach, they are D1. Okay, little bit far, they are D2, and extremely towards the major vessels, they are D3. Okay, so apart from these lymph nodes, whenever the other lymph nodes are involved, okay, it is known as a metastatic CA stomach. Okay, because these lymph nodes are usually distant lymph nodes. Now, what are these lymph nodes? I think all of you know the names. Okay, a left supraclavicular lymph node. Okay, second is what? Your umbilical nodule, which is known as system Mary-Joseph nodule. Second is third, your Irish nodes, which is classically seen in your left axillary region. Okay, left supraclavicular nodes are also known as profuse sign. Okay, so now the question is, why do we exactly get left supraclavicular and left axillary nodes? Okay, many of you know this. I've described this in the clinics before. Okay, because you are asked this thing exactly in the exam. Okay, so your thoracic duct that drains the abdominal region goes up, turns, and goes and drains at the junction of left IJV and left subclavian. Okay, now because of this, whatever lymphatics are just proximal to the site of the junction. Okay, now because the tumor cells are going in this part, if there's any obstruction in this part, the tumor cells will go retrograde. Okay, this will first go to a left axillary and left supraclavicular. Okay, so that is the reason. That is the reason why you get your supraclavicular left side and left axillary lymph nodes and not on right. Okay, so this is very important. Why you should know the reason why all of this is seen. Okay, now there's another sign that is seen. I don't know any of you know this sign. Okay, this sign I think I'll again keep it as a question. I'll just give you a hint. This is also known as your migratory thrombophlebitis. Okay, I'll just describe it. Never mind. So, in a case of malignancy, many a times because the patient goes in a hypercoagulable state. Okay, in that case, there's widespread thrombosis seen in multiple vessels of the multiple veins of the body. Okay, which is even distant to the site where the primary malignancy is. Now, this if involves the superficial veins, leads to thrombophlebitis of the veins. You know what it is? It is basically inflammation of the superficial veins. Okay, so that when seen at multiple sites, leading to pain at multiple sites with swelling inflammation, that is your migratory thrombophlebitis, usually seen in a case of a pancreatic malignancy. Okay, so this is something you should know. Okay. This was the most basic part that we have seen, and all of this general exemption part you should know. Okay. Okay. Now we'll come to specific part of the examination related to stomach or epigastric lump. Okay. Whenever we are starting with abdominal lump, I think you all know how it goes and what is the basic sequence. So we start with inspection. Okay. Inspection of any abdominal lump starts with your abdomen. Okay. Abdomen, the first thing that you see is how's the skin. Okay, you see the contour of the abdomen. Okay, contour of the abdomen, either it's flat, it's elevated, or it's what scaphoid abdomen. Okay, or a distended abdomen, or it's flat. Okay, so this is important. Scaphoid abdomen, I would say that unless the patient is very much malnourished, you prefer not to say scaphoid abdomen, because then your entire viva goes on malnutrition and undernourishment. Okay, so your viva will go towards nutrition. It's better to say that the abdomen you felt was flat. Okay, if it's unless the patient is very much malnourished. Okay, second thing is the umbilicus, the position of the umbilicus. Okay, is it deviated upwards or downwards based on whether there's a lump which is pushing the umbilicus. Okay, if there's a pelvic lump, the umbilicus will be pushed upwards or at the same time downwards. Okay, is the umbilicus everted, inverted? Everted will be in cases of ascites, tense ascites. Usually, normal ascites does not cause eversion of the umbilical lump. Okay, or is there hernia? Many a times the patient has umbilical hernia. Very umbilical hernias are very common. It's a good thing if you're able to find umbilical hernia, because you just ask the patient to cuff, or you ask the patient to do a leg raising test. The umbilical hernia will immediately become prominent. Okay, so always see if the patient has some umbilical hernia, because that is also important operatively whenever you're planning to operate, going through a lap surgery, because you have to make an opening at the site of umbilicus or an intra-umbilical incision. Okay, so knowing whether the patient has umbilical hernia is very important, or very important in the case of any abdominal case. Okay, there's second thing. Third thing that you have to see is the lump. Now, the coming to the lump, there are few points which you all should know whenever you're describing a lump. First, few points come in the inspection, and then rest of the points they come in your palpation part. Okay, the most important thing that you have to start with is the position of the lump. Okay, when you start with position, any position or any time you're describing any lump or any swelling in the body, the swelling has to be described with relation to bony landmarks. Okay, or significant landmarks. Now, if it's an epigastric lump, suppose the lump is somewhere distant. Okay, so you have to say that the lump extends these many centimeters from the xiphoid. Okay, and side to side it's these centimeter, either 7 centimeter or 8 centimeter, whatever step you can. Inspection, you are not touching the patient. Okay, so you can be approximate in your inspection findings. Okay, but palpation, you have to take a tape and measure the lesion. Okay, now it's always a finding, because we have the patient with us. It's always better to see with the tape and give a similar finding in your inspection part. Okay, so position of the lump, position from your body landmarks. Okay, starting from the xiphoid, starting from the umbilicus. Okay, then comes your shape. More than the shape, the margins. Okay, are the margins of the lump seen clearly? Only if seen. If not seen, you can just say that it's approximately this shape or this size, or the margins are seen irregular, or there's a depression in the margin, whatever. Okay. Second thing that is more again important is condition of the overlying skin. Now, if it's a benign swelling, non-inflammatory swelling, obviously it will only be seen or not seen. The lump will be the only thing that will be seen. Now, if it's an inflammatory swelling, either because of could be even malignancy, or could be because of any infection. Okay, there will be overlying redness or overlying sinuses or overlying scars. Okay, so that is another thing you should describe whenever you're describing a lump. Okay, the next thing that you have to see with any lump is movement with respiration. Okay, now this thing is where all of you fumble in the final year viva, because movement with respiration is only seen. This please remember this point. Movement with respiration is only seen with lumps that are attached to the diaphragm. Okay, so only those organs that are attached to the diaphragm will move with respiration. Okay, so a better way to remember all of this is any lump that is below the umbilicus will not move with respiration. Okay, anytime in the exam you get a lump that is below the umbilicus, never utter the word that it's moving with respiration or not moving with respiration. Don't say anything. Okay, Epigastric lumps, RHC lumps, LHC lumps. Okay, you can say that the lumps are moving with respiration. Okay, renal lumps, if they are very huge, obviously they won't move. Okay, but sometimes uh, there's some this thing movement with renal lumps, because if it's a suprarenal swelling or if it's a upper pole swelling, they are in touch with the diaphragm and then it moves. Okay, so there's slight movement with respiration with renal lumps, but all the other lumps they don't move with respiration. They move with respiration only in the only above the umbilicus, and below the umbilicus they don't move. Okay, this is not how you see in the exam, but this is just a way how you have to remember this. Okay, so just remember this point. This is very important point, and all of you fumble with this point. Okay. Third thing that you get to see is visible peristalsis. Now, this thing is very important in an epigastric lump. Okay. I think most of you must have read about congenital hypertrophic pyloric stenosis. Okay. In a case of CHPS or even adult gastric outlet obstruction, the stomach tries to push the contents distal to the site of obstruction. Okay. So when the peristaltic waves are very significant, you can see that the waves are seen moving. You'll see that there will be peristalsis seen from the left hypochondriac to either the RHC region or the RIF region. Okay. Now this is classically seen in your gastric outlet obstruction or your congenital hypertrophic pyloric stenosis. So there will be peristalsis seen from the left to the right side of the abdomen. Okay, this is very important. If it's seen, it's seen. If not, you don't say anything. Again, hernia sites are very important in a case of any abdominal case, because that could be an etiology leading to pain. Okay, so hernia sites have to be examined, especially the inguinal hernia sites. Okay. Second thing is the genitalia. Is there any abdominal swelling, or is there any genital swelling or the genital malignancy that has led to an abdominal lump? Okay, there's a very good image in uh, your SDAS where the patient has a scrotal swelling, and then he has secondary swelling in the abdominal region because the the testis goes and involves the lymph nodes that are present in the para-aortic region. Okay, so that leads to a huge lymph node in the para-aortic region in the case of scrotal swelling. Okay, there's a very good image. I think someday if you get time, please go and see. Now coming to the palpation part. Palpation part, I think we have discussed most of the findings. Whatever findings we have discussed in the inspection part, they come in your palpation as well. Okay. Apart from the normal findings that you get in inspection, the other findings that you have to focus on is the margin, because obviously that is seen better that is felt better in your palpation. Now you all know the palpation is always done with the patient relaxed. Okay. You have to flex the knees of the patient. Okay. Uh, you ask the patient to breathe normally through the nose. Okay. Best thing to now this is important in the case when you are trying to elicit tenderness. Okay. So whenever you're trying to elicit tenderness, you ask the patient questions that are not related to the disease. Okay. You talk about whatever profession he is, what he is doing, and all. And at the time, you go towards the lump or to the area that is involved, and then you try to palpate. If at that point, when the patient is not paying attention to the lump, if at that point the patient is having pain, that is your true tenderness and the patient is not malleable. Okay, that is how we go and check for tenderness. Okay, that is one thing. Tenderness, margins. Okay, either they are regular margins or irregular margins. Okay, any notches that are felt in a case of splenomegaly or anything. Okay, then overlying temperature. Okay, that is best felt with the back of your hand. You all know this thing. Okay, because that again goes in a face of in favor of your inflammatory swellings. Okay, the next thing that you get is mobility. Okay, lumps that are inside the abdomen or that are attached to a pedicle are usually mobile. okay, or if the organ that is concerned is not attached to any fixed structure, okay, like the retroperitoneum, okay. So usually intraperitoneal lumps or bowel lumps arising from the intestine, they're usually mobile, okay. Uh, any other lumps, they are usually immobile. Now, at this point, I want to discuss something known as palatable swellings. Okay. So, for palatable swellings, how do you do palatability? It's mainly seen with renal swellings. Why? Uh, the concept of palatability is that it's seen with swellings that are pedicle. Okay. So, to check for palatability, I hope I'm visible. Your right hand should be right beside beneath the flank region, and your left hand on the swelling. Okay. And at the same time, you have to just give a gentle push on the right hand. Okay. If with this push, the tap or the impulse of the swelling is felt on the left hand, gentle palpation of the left hand, that is your palatable swelling. And this is only seen with your pedicle swellings. Now, which are your pedicle swellings? One is your suprarenal swelling, your renal swellings, or your ovarian swellings. Okay. All of them, they have pedicle. Okay. At the same time, there's something known as external and internal palatability. Okay. External is what I've just demonstrated. One hand is in the flank region and left second hand is in the is over the lump. Internal is seen in a PV examination. Okay. So when you do a per vaginal examination, so suppose this is the uterus, this is your renal, this is your suppose OV, and there's a ovarian swelling. Okay. Now when you go in the phonesis, if you go in the lateral fornix, okay, and again you keep your left hand on the swelling and right hand with the PV, you go in the lateral fornix, okay, and you push the swelling up, okay. This will give an impulse to the left hand, okay. This is how you demonstrate your internal palatability, okay. So one hand is in the lateral fornix and second hand is over the swelling. This is your internal palatability. Okay, so this is important. Many a times you ask this question in the exam. Okay, what is internal palatability? Another thing that you have to see again with the renal swelling is your bimanual palpation. It's the same thing. You compress both the hands at the same time and then try to feel the surface of the renal lump. This is your bimanual palpation. Okay. Apart from this, the other test that you can do is your leg raising test. Okay. This is mainly done to differentiate your. There are two tests that are important in this part: your leg raising test or your head raising test. Okay. And second test is your knee elbow. Wherever your swellings are superficial or you feel that you are not able to differentiate between whether it's an there are three levels of swellings or abdominal swellings or abdominal lumps that you get. Okay. One is your parietal swelling. Parietal is anything that is related to the wall. Okay. Second is your intraperitoneal swelling. And third is your retroperitoneal swelling. Now, to differentiate these swellings from each other is what you do these tests: the leg raising, head raising, and your knee elbow. Okay. So, if you have to see a swelling that is in the epigastric region, okay, you do something known as the head raising test. Because that will cause contraction of the muscles in the epigastric region, okay, your rectus muscles and your obliques. Okay. So If those muscles are contracted, your epigastric swelling that are parietal or in the wall will get prominent. Either your hernias, okay, or is there any weakness, okay, or swelling that in the parietal wall, which can be hematoma, or it can be lipomas, or it can be sebaceous cyst or anything, because the muscle layers will push the swelling upwards, okay, and this will make the swelling prominent, okay. Now, if the same swelling is present in the lower abdomen, okay, you have to do a leg raising test. It is also known as your Carnet's test. Okay, so these are two tests that are important. Now, what is knee elbow position? Okay, so for this, I'll try to demonstrate, try to draw a diagram. This is just a rough diagram. Okay, suppose this is the abdomen. We are seeing it from a lateral view. Okay, and we draw an imaginary line over here. This is your peritoneal surface. Okay, all your retroperitoneal organs. Okay, that is the lateral colon, your pancreas. Okay, your aortic swellings, your aorta and all. Okay, all these structures they are retroperitoneal. Okay, and rest most of the structures they are intraperitoneal. Now, what happens is to differentiate whether the swelling is retroperitoneal or intraperitoneal, we do something known as knee elbow position. Okay, so if you ask the patient to uh, stand on all the to bend on all the four limbs, that is your knee and elbows. Okay, the lump which is in the peritoneum will fall forward. Okay, because it's not attached to any structure in the retroperitoneum or the vertebrae that is fixed. Okay, so this lump which is inside the abdomen will fall and come forward. Okay, at the same time, if there's any lump that is attached to the retroperitoneum, will not fall forward. Okay, so lump that becomes prominent on knee elbow position is your intraperitoneal lump, and one which does not become prominent is your retroperitoneal lump. Okay, so this is very important. But because this test is painful and can lead to many complications, this knee elbow test is not done. Okay, so this is one test you should not do, but you should know the concept what is exactly done. Okay, this is most of the part of palpation that we have already discussed. Okay, now there's just one thing that is remaining is pulsation. This time we are discussing it all of this in somewhat detail. Okay, but next time so that we can go a bit faster. Okay. Now, pulsations usually there are two types of pulsations that are seen. One is expansile pulsation, okay, and one is transmitted pulsation. What are expansile pulsations? Suppose there's a swelling in the abdomen that has pulsation, significant pulsations, okay, and if those pulsations are coming from a swelling that is arising from the vessel, from a major vessel, either the aorta, okay, suppose it's an aortic aneurysm. If you keep your fingers, okay, over the swelling, your fingers will separate or move away from each other. Okay, this is your expans. These are your expansile pulsation. Okay, at the same time, if there's just uplift of the fingers and there's no separation of the fingers, these are your transmitted pulsations. Okay, now expansile pulsations they are seen in a swelling arising from the vessel itself. Okay, something like an aortic aneurysm. And that is when there's a tumor that is sitting on the vessel, okay, this will do to your transmitted pulsations. Okay, so this is another thing you should remember. Okay, there's most of the part of examination in palpation which is different from uh, your inspection. Okay, percussion. I think you all know what all is done. Most of the part is not significant. You just have to see what is where you're getting the dull note and what part you're getting the tympanic note. Okay, liver dullness and all we'll I think discuss at the time of when we discuss an RH lump. Okay. Apart from this, again at this point you have to go and see the external genitalia. Okay. Because cuff impulse and all you'll only see in palpation and not in this thing. if it's not significant in palpation and not in inspection. Okay. Percussion, something if there's uh, ascites is another thing that you have to see fluid trail along with shifting dullness. Okay. Uh, Coming to auscultation, auscultation again, if there's something important, that is your peristaltic sounds. Either if it's a bowel pathology, there will be increased peristaltic sounds if there's obstruction, any kind of obstruction. Okay. And second thing that you will get again in this case where there's a swelling sitting on the vessel is a bruit. Okay. So these two things are important in a case of auscultation. Coming to a diagnosis, as I've said, diagnosis in these cases most commonly will be a CA stomach or it will be a pancreatic swelling. Okay. And based on that, we'll see what management we are doing. I think for now we'll limit the discussion because it's already late. Let's not hammer all of this on you today itself. Maybe next part we can discuss the management and treatment part and what how we go ahead with a pancreatic and gastric lung, and maybe we can discuss another small topic with it. Okay, so let's end the session for today. If there are any questions, please let me know. Oh, that's simple. Yeah, so bicarb decreases sodium activation of iron. Yeah, so what happens in paradoxical aciduria is because there's activation of RAS, which is right. The body tries to absorb the sodium in replacement of potassium and hydrogen pump, which is present in the DCT. Okay, your distal convoluted tubule. Now, because the patient is already having low potassium, instead of giving out potassium, the body gives out H plus. Okay, so this is how you get H plus or acid excretion in your DCT, and you get paradoxical aciduria. Okay, so yes, that is right. Okay, I think we are done for a day. We'll have another session based whatever topics we have discussed before. Okay, yeah. Thank you so much. Any doubts, any other doubts, please share, or you can even text me. Okay, thank you. Good night.